Hello students, this is our third lecture and we're going to talk about hemoglobinopathies. So first let's define hemoglobinopathies. These are a family of genetic disorders. It's caused by a production of structurally abnormal hemoglobin molecule or synthesis of insufficient quantities of normal hemoglobin or both of them. So we can classify hemoglobinopathies into different types. We have what is known as qualitative abnormalities. So basically the abnormality will be in the structure of the globin chain, and this will result in sickle cell disease. And also we have a quantitative abnormalities in which the structure of hemoglobin is fine, but it's produced in less quantities, whether it's the alpha chain or the beta chain. And this will result in a disease called thalassemia. So let's start with sickle cell anemia. The sickle cell disease is a type of hemolytic anemia. It is caused by a single base mutation. It is called point mutation. This mutation will affect the beta globin gene that changes the sixth amino acid from glutamic acid to valine. So if you remember, the beta globin gene located on chromosome 11, and this gene will have a mutation, a single point mutation. And this mutation will cause exchange or substitution of the glutamic acid with valine at position number 6. So as a result, when the glutamic acid is replaced by valine at position number 6, this will result in replacement of HbA into HbS. So the person with this mutation will have HbS. Classification of sickle cell disease. We have sickle cell anemia and we have a sickle cell trait. In sickle cell anemia, there is a homozygous state, and in this case, the person will inherit two mutated alleles of the beta globin gene, and this will result in both of the beta globin chains will be abnormal or defective. While in sickle cell trait, there is a heterozygous state where one allele is defective, and this will produce HbS. And the other allele will be normal, and this will produce HbA. So the person will have a combination of HbA and HbS. Pathogenesis of sickle cell anemia. When HbS is deoxygenated, the molecules of hemoglobin will polymerize to form acidocrystalline structures known as tactoids. These tactoids will distort the RBC membrane and produce characteristic sickle-shaped cells. So this is the HbS, and when HbS is deoxygenated, this will stick together and form long fibers called tactoids. These are the tactoids. And these long fibers will push the RBC membrane out of shape, causing the whole cell to become rigid and take the sickle shape. So it will look something like this. Clinical features of sickle cell disease. The disease usually does not manifest itself until 6 months of age. So, this disease does not manifest itself until the 6 months of age. This is because in the first 6 months, the infants will be protected by high level of HbF. So, symptoms of sickle cell anemia manifested after 6 months of age. Irreversibly sickled cells have a shortened survival. Normal RBC have a lifespan of 120 days, while sickled RBC will have a lifespan of just 10 to 20 days. So these cells will have very short survival, and the sickled cells will block vessels in the microcirculation. So these cells will form clumps and block the blood vessels and leading to tissue infarction. And will cause vaso-occlusive crisis. Vaso-occlusive crisis means plugging of small vessels in the bone produces acute severe bone pain, and this will affect areas of active marrow, like the hands and feet in children, and this is called dactylitis, or the femur, humerus, ribs, pelvis, and vertebra in adults. Patients usually have a systemic response with tachycardia, sweating, and fever. And this is the most common form of crisis. The vaso-occlusive crisis is the most common form of crisis in sickle cell disease. Investigations of a patient with sickle cell disease. We do an HB test for those patients, and they will be anemic. The HB usually from 6 to 8 grams per deciliter. And also we do a blood film. In the blood film, we see a sickle cells, and there's increase in reticulocyte count to 10 to 20%. Also, we do a sickle solubility test. This test is based on the relative insolubility of HbS compared to HbA. So we put a mixture of HbS in a reducing solution, such as sodium dithionite, and this will give us a turbid appearance. Because of the precipitation of HbS, whereas normal HbA will give a clear solution. So if you can see here, this is HbS, this is a turbid solution, while this is an HbA, this gives us a clear solution. You can see the lines behind the tubes. So this is an HbA, and this is an HbS. HB electrophoresis is required for the definitive diagnosis of sickle cell anemia. So in homozygote, there is no HbA band, and there is a predominance of HbS, while in heterozygote, there is an HbA and HbS bands. So this is a normal person. This will have an HbA, HbF, and HbA2, while a patient with sickle cell anemia will have no HbA, only HbF, HbS, and HbA2, while a patient with sickle cell trait will have an HbA, HbF, HbS, and HbA2. Treatment for a patient with sickle cell anemia. All patients with sickle cell disease should receive prophylaxis with daily folic acid, because there is an increased folate requirement due to hemolysis. So we give them folic acid as a prophylaxis. The vaso-occlusive crises are managed by aggressive rehydration, oxygen therapy, adequate analgesia due to severe pain, because to manage the severe pain of those patients, and antibiotics to prevent infections. Regular transfusion to suppress HbS for patients with recurrent severe complications. So let's discuss now the quantitative abnormalities of hemoglobin, which again they're known as thalassemias. So thalassemias, they are hereditary hemolytic diseases in which there is a reduced rate of production of one or more of the globin chains of hemoglobin. This basic defect results in imbalanced globin chain synthesis. So in thalassemias, you would have either more alpha than beta or more beta than alpha. Classification of thalassemias. Thalassemia is classified according to which globin chain is produced in reduced amounts into either alpha thalassemia or beta thalassemia. In alpha thalassemia, it results from deletion of one or more of the 4 alpha gene alleles, coding for the alpha globin chain in hemoglobin. So the main reason why a person would have alpha thalassemia is deletion rather than single point mutation. Now remember, we have 2 alpha gene loci on chromosome 16, and therefore each individual carries 4 alpha gene alleles. So as a result, we have clinical syndromes depending on the number of the alpha globin genes deleted. So if one gene is deleted, this will result in silent carrier state, and those individuals will be asymptomatic. They will have no symptoms. If two alpha genes are deleted, this will result in alpha thalassemia trait, and those individuals usually asymptomatic, they have normal hemoglobin, or they will have a minimal anemia. If 3 alpha globin genes deleted, this will result in hemoglobin H disease, and this will result in moderate anemia. While the most severe form, when we have 4 alpha genes deleted, 4 alpha globin genes deleted, this results in a condition called hydrops fetalis. It's a severe form and it's fatal and usually results in intrauterine death. So in hydrops fetalis, you will have a tetramer of gamma chain, and such hemoglobin, which is a tetramer of gamma chain, it's called HB-BART, and HB-BART has no O2 carrying capacity. So this would result in O2 starvation of the fetus and results in death. Now the beta-thalassemia. Beta-thalassemia results from point mutation in the beta-globin gene, resulting in a reduced or absent synthesis of the beta-globin chain, and it's the most common type of thalassemia. Now, there are different types of beta-thalassemia depending on the severity of the mutation. So clinically, it can be classified into 3 groups. Either thalassemia minor, if one gene is affected, the person is a carrier and has mild anemia. Thalassemia intermedia, patients with thalassemia intermedia have varying effects of the disease. Mild anemia may be their only symptom, or they may need regular blood transfusions. Thalassemia major, it's the most severe form of beta thalassemia, and it develops when the beta globin genes are missing. So in normal hemoglobin, we have beta chains, while in a patients with thalassemia, beta thalassemia major, have only alpha chains. There is no beta chains because the beta globin genes that codes for the synthesis of the beta globin chains will be missing. Clinical features of beta thalassemia major: patients presents within the first year of life with failure to grow, poor feeding, and there's recurrent attacks of infection. The signs will be, they will be pale, jaundiced, and they will have a hepatosplenomegaly. Investigations of thalassemia, we do an HB test. This is more severe than sickle. The HB will be from 2 to 8 gram per deciliter. And in the blood film, there is microcytic hypochromic anemia with reticulocytosis. There is the microcytic hypochromic anemia. It's because of reduction of HbA available overall to fill the RBC. So in turn, this will lead to RBC into microcytic. And hypochromic means it's more pale than the normal RBC. HB electrophoresis, the HbF level is always elevated in those patients. And in thalassemia major, there is only HbF and HbA2. There is no HbA1. HPLC, high-performance liquid chromatography, is used to separate and quantify various normal and abnormal hemoglobin. Treatment of thalassemia. Alpha-thalassemia. There is no treatment needed for alpha-thalassemia trait, while transfusion for hemoglobin H disease. Beta-thalassemia. There is no treatment is needed for beta-thalassemia minor, and transfusion or bone marrow transplantations for beta-thalassemia major. Thank you.